Good morning, everybody. Welcome to Trisikon 2010. And I'm glad to announce again we will have a full audience within an hour and a half. I'd like to welcome the participants. I'd like to welcome the chair people moderator. As a change, I'm welcoming you, but eventually you'll be welcoming everybody else. And this time we are continuing the same tradition. There are slight changes this time. The first change is we are starting even half an hour earlier than before. And we had a debate last night whether there will be about 20 people. So I already see about 35 people. So we are better off. And I heard that there are about 150 outside. So we should be rolling in few minutes. Around 11:30, we have a Trisikon oration with Dr. Ashit Jain, who has flown in from USA just for one lecture, followed by which there is a lecture you should not miss. It's a dream come true, and I won't talk about that till that time. So let me start my first talk, and the talk is there a role of clinical examination in today's era? My talk today is that what is the role of clinical exam in the era of imagining today? Now, if you look into 20th century, that is the last century, in the first half, the doctors really developed an art towards medical history, examining the heart, interpreting the ECG. They were the clinical cardiologists. They were fantastic. In mid-1900s, phonocardiography, ECG, hemodynamic, angiographic findings came. That made exam even much more important. But then, by late 19th century, late 1900s, 1980s, 90s, things really gotten into worse. And this is a data collected in America in mid-1990s, where they evaluated cardiology fellows, medical residents, medical students. And what they found was accuracy in identification of murmurs and different extra heart sounds was anywhere in residents being worse than students. Could you see residents are this green here? Some places they are worse than students. As low as only 10% to 30%. So somewhere in late 1900, people started believing that the auscultation skills were not important. Why was that? Well, I don't have a real answer, but this could be one of that. What do you want to be when you grow up? So my daughter tells me a doctor, and she is going to become a doctor. What's the most important thing to remember to be a good doctor? She says, don't get sued. So the entire medical field started going towards extremely defensive, high imaging, high technology area where everybody wanted protective. So let's now talk about science and art of a great clinician. So let's start with history. Now you'll all be wondering, what am I, an interventional cardiologist, talking to you about history? Where before you see a patient, it's very important to review all the available information, outside sources, past personal history, and then provide the patient to give an opportunity to give a narrative of his medical problem. And I'll tell you, this is the most important thing. Listen to the patient. Family members are allowed to be present. I always have as many family members. If you have a small clinic office, expand your office. The more the merrier. And most patients want their doctors to listen. Clinicians should minimize note-taking and focus on the patient. Don't write down. You have enough short-term memory that you can write when the patient finishes talking. Direct questioning by the doctor adds to the insights. So once the patient has finished the narrative, go back and talk to him as what he explained to you. And delegating this history to inexperienced person, and that is happening now. Lot of hi-fi doctors, lot of high busy volume keep assistants, associates who take the history. This is not good because it adds to inaccuracies and omissions. And a doctor-patient bond is not established. This bond not only is fantastic, it is a placebo effect. How many times the patient comes to you and tells you, "Doctor, seeing you makes me feel already better." And if you don't have patients telling that to you, there's a problem. Then we'll sit in lunchtime and I'll tell you how to improve. But believe me, half of your patient or maybe 90% of your patient should, when they come and see you, should tell you that they feel better when they see you. And this is always helped by gentle humor. Humor should be a part of doctor-patient relationship. So to summarize, review the records first. That is the new style. Don't take the history if the records are there. Go through the records. Just glance it. It will give you in a very short time lot of background information which you are going to search. Then listen to the patient's narrative. Subsequent focus questioning. Get a differential diagnosis during the interview. Start pathophysiologic thinking. Don't think of the stock market. If you want to think of stock market, come and listen to my Sunday's last lecture, how to invest wisely and sleep nicely. And except for sleeping time, don't think of the stock market, and during sleeping time too, because I know lots of doctors, while the patient is talking, they are still interested in either watching something or their mind is wandering. You should be focused on the patient. Family history is very important. A doctor-patient bond has to be established, cannot be delegated. A deaf elderly gentleman finally decided to see Dr. Shah, who had fitted him with a hearing aids. The patient went back to the doctor. Doctor checked his hearing. After the exam was complete, he said, "Your hearing is perfect. Your family must be so pleased that you can hear again." The patient says, "I haven't told my family yet. I just sit around, listen to conversation, and I've changed my will 3 times this month." The story is, keep your ears open. Many times, believe me, many times, I have patients' families sitting outside and commenting on things like economics, commenting on criticism of how somebody had an angioplasty wrongly done. If you hear that with your ears open and you encounter that patient, be sensitive to that issue that he was unhappy with his previous doctor or something. Physical exam is very important, of which height, weight, BP, heart rate, BMI is very important, and don't forget white coat hypertension. If a patient comes to you, the blood pressure is high, there's enough document that blood pressure needs to be rechecked 2-3 times, maybe by the nurse, a pleasant looking nurse, or have the patient check the blood pressure at home and come back. Peripheral exam, very seldomly done, should more frequently be done. Carotid bruits are mandatory part of any cardiovascular exam. Abdominal aorta and femoral arteries. Palpation truly has become a lost art. Even I don't do it all the time, but when you do it, it is palpated in the left lateral decubitus position, and the areas where palpation helps, such as parasternal lift, mainly in large anterior MI, looking into the apical impulse in left ventricular dilatation, a hyperdynamic diffuse impulse in aortic and mitral regurg, a discrete and lifting in aortic stenosis, rare palpable gallops, and in dyskinetic area. And you should do it. It's only 2 minutes, and again, this is a part of that bonding. You have to understand, a bonding between a patient and doctor is a lifelong bonding. It's a commitment. It's something that should not be forgotten. Cardiac auscultation, as I mentioned in my earlier slide, is a widely neglected and fast becoming a lost art. And there are 3 reasons to that. Lack of good teachers. And I'm proud to tell you that in our group we have excellent good teachers, definitely led by none other than Milan Chugh and all my colleagues, Urmil, Anish, Hemang, Satyagupta, Jay Nayak. They are brilliant clinicians. Lack of availability of patients with advanced findings, which is true. We are not seeing as much mitral regurg, aortic regurg, rheumatic fevers, bad gallops anymore. We are seeing people with S4 gallops at the most. And finally, poor techniques, because nobody has taught us the techniques, so things have fallen out of there. So optimal cardiac examination requires quiet environment. Please, very quiet environment. This is when make sure there's no noise outside. A systematic approach for valve and cardiac cycles. You have to have a focused search. When you're putting a stethoscope, you have to look for something. Just don't keep a stethoscope. If it's mitral valve prolapse, listen for clicks. If it's a rheumatic patient, listen for murmurs. If it's an ischemic heart, look for gallops, ludup-dup or loop-dudup. And again, on the third day, we have a whole music of the heart session on Sunday. Supplemental techniques are very important, postural. Sometimes have them walk around and come back. And if you think you hear it, you probably hear it. Don't ignore it. And stethoscope connects the doctor to the patient. So the impression I'm trying to bring it to you is, please, please, please connect to your patient. Cardiac murmurs are produced by abnormal pressure gradients, abnormal communications, turbulent blood flow and consequent vibrations. And there are murmurs. Murmurs have intensities. Typically graded systolic murmurs are 1 to 6. One murmur takes few heartbeats before you hear it. A grade 6 murmur is palpable. 4 or above is palpable. Diastolic murmurs are difficult to hear, rarely palpable, and graded 1 to 4. You do hear innocent murmurs in young due to flow, and in elderly due to turbulence from sclerotic valves. Diastolic murmurs are always pathologic. Mitral valve prolapse many times is overdiagnosed by echocardiography, and I truly believe that for mitral valve prolapse you have to have supplemental auscultatory findings, including body findings like skeletal deformities, auscultatory findings which are intermittent, clicks, late systolic murmurs. Upright posture is very important. If you do find mitral valve prolapse on echocardiography, stand up the patient, listen to the patient, and loud mitral regurgitation may not indicate severe. Sometimes you have more noise. Gallop rhythms have a poorer prognosis, mainly S3 gallops. They are subtle, heard only in quiet environment. Bell should be placed directly and lightly over the point of maximal impulse in the left lateral decubitus. Hemodynamically, they represent systolic or diastolic misperformance. Valvular heart disease is itself a whole day session. In 2 minutes, aortic stenosis, take the carotid upstroke, should be normal in the elderly, but slow otherwise in the aortic stenosis, absent or very soft, barely audible A2, but a loud S4, and if the systolic function is very poor, there is gallop, S3. Radiation to the carotid arteries is present. 3 to 5 harsh or musical murmur may be blowing in elderly, blowing in the apex, and there is always a soft aortic regurgitation murmur in most of the aortic stenosis patient, and they do not have significant hypertension, less than 200, mostly tight aortic stenosis, systolic hypertension is less than 160. Aortic regurgitation, the pulse pressure is very wide, lots of Steins, which I won't go into it, which we studied in medical college. We don't see that as frequently, but the arterial diastolic pressure is low, laterally displaced hyperdynamic apex, Austin fleet diastolic rumble is almost invariably present if you are very careful. Gallop again is present, which is a poor sign, and rapidly crescendo blowing diastolic murmur, at least grade 2. Mitral stenosis, there is a parasternal lift. JVD is prominent V wave, prominent A descent, increased intensity P2, a rumble, at least grade 2 is present, pan-diastolic. S1 is palpable, maybe grade 2 to 3 murmur of MR. So this aortic stenosis will have a AR murmur, AR will have a soft systolic murmur, MS will have a MR murmur, and mitral regurgitation will have a parasternal lift with a diastolic flow rumble too. So in valvular heart disease, take your time to see the dual murmurs, systolic and diastolic. What's more important now is that despite enormous advances, our technologies are imperfect. Tests are erroneous, misleading, conflicting, multiple tests are employed. And I'll tell you my wife's example. My wife 5 years ago during an X-ray exam had a knee joint pain. She had an MRI done. She was found to have some white density. Immediately a diagnosis of sarcoma was made. I didn't tell her she had sarcoma. We took a plane ticket to go to Sloan Kettering. But the people who read the MRI told me that we are not sure. Do go and see Dr. X in Bombay. When we saw Dr. X in Bombay, he told us that this is just a normal variation. And definitely we cancelled the ticket, went, got a suite in Marriott Hotel and spent 2 days in Bombay and had a good time. Story doesn't end there. Last year we had another bout of coughing with my wife, and I like my wife's stories. You'll see those jokes. And she had incessant coughing for almost 6 months. We got an X-ray. X-ray showed a defect. We went with a CT scan. CT scan showed a spot. Again, the radiologists were worried, genuinely worried. We consulted a friend, Dr. Iyengar and Atul Patel, and after lots of basic examination, what they did was prescribed antacids and had us put 2 bricks at the head end of the table, and it was gastroesophageal reflux causing into lungs, causing some degree of atelectasis. So we avoided a bronchoscopy and biopsy. A good bronchoscopist was ready to bronchoscopy. And a good pathologist said, we'll read your biopsy and fly with you to Tata Memorial. So I told my wife that now you'll never have any malignancy in life. You have already had a squamous cell carcinoma from gastrointestinal reflux, and you had a sarcoma which was wrong. But again, a good clinical exam, and I'm proud to tell you, we have good clinicians in town. So a clinician cannot blindly rely on technology alone. So a single specialist used to follow the patient. As time has evolved, workforce, patient loss, quality of care, everything has increased. So new concept is coming in America, which is conjoined care, where a cardiologist, in example in cardiology practice, works along with primary care physician. And the reason is cardiovascular diseases are chronic, and a long-term disease process has to be followed. So observing the natural history of heart disease unfold, it is very difficult for a single very busy physician to track. So somewhere a joint follow-up technique has developed. Along with that, lot of clinical trials have brought in drugs, device, guidelines, information, and new imaging technology have supplemented. So in future, I won't be surprised that the physician payment may be tied to documentation of evidence-based medicine, not the gunshot medicine. And simple reassurance in the decision-making process will make it much more rewarding to the physician. And clinical experience from long-term care produces wisdom. And I was amazed. While preparing this slide, I went through all the textbooks of my children who are in first, second and third MBBS. And in internet. There's no textbook I could find in India or in literature which has a chapter on wisdom. So that is something I would recommend Dr. Gupta, Dr. William Vines, visionaries, to write a chapter in our textbook on wisdom. Oldest form of continuous learning is follow-up care is truly the oldest, most effective life learning curve. And lastly, to end, again a small story which I have told you before. Hello, the caller said to the nurse, you have a patient named Dinesh Bhai on the floor. Can you tell me how is it doing? The doctor removed his stitches this morning, said the nurse. He's doing fine. He had ultrasound of his bladder. He has 5 other blood tests. He will be discharged in 1 or 2 days. Thank you, said the caller. The nurse said, would you like to tell Dinesh Bhai that you called? This is Dinesh Bhai, the caller said. My doctor doesn't stay in the room long enough to tell me anything. So the key points Is clinical exam, history taking, talking to the patient is still the cornerstone? Physical exam findings do provide evidence-based information, and clinical exam requires commitment and practice. To summarize, it will lead to higher patient satisfaction, less morbidity, lower mortality, less cost, proof of clinical competence, and a good long-term care is the best form of CME. Lastly, I want to thank you, Dr. Patel, said the young man, heartily shaking the doctor's hand. I gained great benefit from your treatment. Dr. Patel looked at him blankly. He said, I'm sorry. I don't think you are my patient. Why are you thanking me? The guy says, no, I'm not. Very happily. My uncle was and I am his heir. Thank you very much. And this is a starter where I'm again going to tell you that clinical exam and clinical competence is very important part of our examination, our entire wisdom, art and science.